He'll be speaking today about smile design in orthodontic treatment planning. And I don't want to waste any more time. I would like to hand over the microphone to Professor George, and we're all anxious to hear what he has to say. Thank you.
Thank you very much, Doctor. It's a great honor for me to be here. Sorry, because at the beginning I was just putting my trying to put my presentation in order. And well, first of all, I want to thank the Iraqi Orthodontic Society for this invitation and the University of Baghdad. It's a great honor for me to be able to lecture, do this lecture from very far away. Right now here in my city in Mexico, well, in Mexico, it's 2 o'clock in the evening. I understand that for you it's 10 o'clock. So I'm really happy and grateful for you to stay here with me to see this lecture. I'm going to try to be very objective, not trying to go do this lecture easily. And I hope that all of you get some tip from this presentation. And if you get 1 or 2 tips, that's going to be very good. Okay, well, like I tell you, it's an honor for me to be sharing with you. The lecture's name is The Smile Design in Orthodontic Treatment Plan, how we can integrate what the concept of smile design. We're going to talk about what is smile design and how can we integrate this to our ortho treatment plan. Okay, that's my name in the lower, Jorge Garcia, that's how you say it. And down there, it's my Facebook and my Instagram. If you want to add me, follow me, it'll be great. I'll share you too. Any question or any doubt that you have, you can, with confidence, you can write me, you can ask me, no problem. You can take pictures, you can take screenshots from this presentation. There's no problem with that. I strongly feel that that we need to share the things that we know. That's why I don't put all the complete faces of my patients because of private issues, but we can see the smiles. Okay. Now, I'm from Mexico. You can see I'm from the other part of the world. And I live in a city that's called Monterrey. That's there with the arrow. We're in the northeastern part of the country. Mexico City, that's the most important city. It's right there in the center. And I live over here. It's around 1,200 kilometers from Mexico City. Mexico is a big country. We're 120 million people here. And the city that I live, we're around 5 million people. This is my city, Monterrey. We have a mountain in the back that's like our symbol of the city, and well, it's a colonial Spanish city. We also have the modern part of the city. We're surrounded by mountains, so it's a very nice place. It's also hot. I know that in Iraq it's very hot. Right now we're around 36 degrees centigrade right now. I know that's hotter over there, but it's a very hot place here. Okay, and well, every time that I start a lecture, I like to start with a phrase, and this one I like it very much from from Albert Einstein. He's not a doctor. That says that education is not learning of facts, but training our mind to think. So it's very important for us, like orthodontists or dentists, to understand the process of diagnosis. And it doesn't matter if you learn a lot of facts or a lot of articles. What's important, you have to train your mind to think when you do some diagnosis. So that's, I know that I'm talking right now to some students. So when you're in your ortho program, the most important thing is to start training your mind to think and to do a correct diagnosis of our patients. So I'm going to start this lecture with this case. I call it was a dilemma for the mom of the patient. It's a beautiful young girl. She had ortho treatment when she was 12 years old. She comes back around 20 years old, 8 years later, to the office, and her mother had the idea to send this girl to do some veneers, for aesthetic reasons. She had a little relapse in the lower, and you can see the canines that they look a little bit flared, but roughly, the occlusion was good. She didn't like that her daughter had like some stains on the enamel right here, and she wanted like perfection. But you're talking about a 20-year-old patient that's very young, very beautiful, has very healthy teeth, and they right now, I believe that's in every part of the world, there's a lot of social pressure of having a beautiful smile. So they they look for treatments like veneers, but we know that that's not always a great solution, or that's not the ideal solution for this problem. I told the patient my opinion was to stay that if she wanted to correct the relapse that she had from the ortho treatment, and if she didn't want to use brackets, we can use liners. You can do a lot of things with ortho, but specifically for aesthetic reasons only. But what would you do with this treatment? So if this patient would have gone with the aesthetic cosmetic dentist, they would have done the veneers with no hesitation. So I believe that dentistry, like a profession, has grown a lot this past years, and but not all this, not everything that we grow or the advancement that we have are for good. I say a lot that we're going into a dark era in dentistry around the world, because every day there's millions of treatments that are done in healthy mouths. There's millions of disease-free procedures performed around the world under the name of cosmetic dentistry, and we're talking about uh, gingival treatments when you do some gingivectomies, veneers, crowns. There's a lot of treatments that probably are not the ideal solution for the patient, but the problem is that patients want things fast and they want it easy. So sometimes, for example, our treatments like orthodontic treatments are not simple. They're not fast. You spend around a year or 2 years in the treatment, and a lot of the patients, what they want is a quick solution. Okay, I'm going to talk a little bit about some introduction in this lecture about aesthetics. Okay, and I'm going to talk a little bit about some articles. The first one is from Dr. David Sarver, that he didn't invent this concept, but he was the first one to put it on a paper about the smile arc. That right now it's it's more, we look more at the smile arc, and Dr. Sarver was one of the first ones to put it in a paper. So the smile arc, it's this is another article for Dr. Sabri from the JCO from 2005, and this talks about the 8 elements of components of a balanced smile, and we can see here on the top bottom what the smile arc is, and the definition is that the incisal edges of the upper teeth have to touch or follow the curve of the upper curve of the lower lip. When you see a smile like that, you can say that it's a balance or it's a nice smile. But that's some of the components of aesthetic that we're going to talk today. Now, this is one article. I'm going to show you this other one. This is from Dr. Wilson Machado. He's from Brazil. This is from Dental Press Journal. I recommend you this journal. Is from Brazil. Our Brazilian colleagues, they work a lot on aesthetics. So I'm going to talk about this 10 components. We're going to talk a little bit about each one. Now, the first one, that's the smile arc. You can see here that when we have a convex, like here on this side, you can see how the incisal edges touch what's the upper part of the lower lip, and that's a very aesthetic smile arc. Sometimes if you have a straight or plain smile arc, sometimes we do that with our bracket placement. If we don't look very good at the position or at the size of the teeth, if we put all the brackets, almost at the same height, the problem is that we're going to flatten that natural curve. Sometimes the patient comes naturally with their smile arc, and if you place the brackets very similar, the height of the central incisor and the lateral incisor, you're going to flatten that curve. Now, sometimes we have an inverted smile arc, and that's when we have a lot of wearing of the teeth. That's typical from older patients or patients that have some malocclusion, that you start wearing the incisors. We can start seeing some inverted reverse or reverse smile arcs. Like, for example, this patient, she has some wearing because of malocclusion. We straightened up the teeth, and after that, what we did was some aesthetic treatment, so she can have longer, she can have more, and we can do put that smile arc on her smile. It's much better looking when we do the aesthetic treatment and not only the ortho. So I can tell you right now that, for example, almost 90% of the patients that we see in the office, at the end, they all go with some kind of aesthetic treatment. Not veneers and everybody, but we do a lot of gingivectomies and we do a lot of bonding. We do a lot of bonding on the incisors so they can have a better or a nicer or more proportional size of teeth. Now, in ortho, what we can do if we modify a little bit the bracket position, like Tom Pitts does. This is a 13-year-old patient. You can see that she doesn't show a lot of she doesn't have any incisor display at this age. And the natural thing is for a patient at this age to show more of the incisors. So what we did a bracket placement that's a little bit more gingival. And with that, we extrude a little bit more the incisors, and this is her smile. At the end, you can see a much better smile. She has a more incisor display, and this is what the changes that we can do with an ortho treatment. Also, in this case, she had a little bit of the incisors ledges bonded because she had some wear in the teeth, but you can see that's a more adequate smile for a 14-year-old patient. Okay, also a very, very important concept, and I want you to see your patients. One of the teeth that has the most amount of size disorders is the upper lateral. So in some patients, for example, we can leave the women have a little bit more like a step between the central and the lateral incisor, about 1 millimeter to 1.5. And in men, naturally, it's about a little bit from 0.5 to 1. But it depends a lot on the size of the incisors. Now, in this case, I can show you a patient that is a female patient that has almost the same size of the central and the lateral, so we don't have too much discrepancy on this. Now, this is another patient. We can see that she has very small laterals. So we need to understand that we need to leave a little bit more larger step between the lateral and the incisor, and then send this patient to an aesthetic treatment. Now, in this particular case, the patient had an ortho treatment when she was a teenager. So they closed the spaces, but they did not, take into account the thing that she had, the fact that she had a very small lateral incisor. So she had her canines in class 2. What we did in this treatment, we sent the canines to class 1. We left some space distal to the laterals so she can have a bonded or a veneer on the lateral incisor. Now, the second part is when we're talking about the proportion between the upper teeth, we can see that we have a golden ratio that's about 62%. This means that the lateral incisor measures 62%, measure distally of the central incisor, if you see him on a picture. Now, the canine is 62% from the lateral. And with the more modern or modified radio, we are talking about it's called like a platinum. It's 70%. Right now, like you can say that a lot of people try or look the aesthetic treatments. We're looking to have a more broader smile. Show more teeth, not that narrow arches. We're looking to give our patients a little bit more broad arcs so they can show a little bit more teeth when they smile. Okay. And you can see, like in this case, where we have a patient that has similar central incisors, but we can see that he has a very small laterals. So what we need in this case is open space, so you can do some aesthetic treatment in the lateral incisors, so he can have a more aesthetic smile. Okay, in this case, we can see a patient that has almost this. It has a very proportionate size between the centrals, laterals, and canines. Okay, also when we're talking about the symmetry or the ratio between what's the width of the tooth and the height. So when we have very long teeth, we're talking about 75 to 85%, of proportion there, radial symmetry. Sorry, it's over 75%. When we're talking about a normal range between what's the width and the height of the teeth, it's like this. 75 and 85%, like we see here. And when we have long teeth, it's about 75 or more, like the proportion of 75%. And here we can see a very short teeth that's over 85%. I'm going to show you some examples a little bit more. Another part that's important is sometimes we have spaces, like we see in this case. We have a patient that has proportionately a smaller lateral. So what they did was an aesthetic treatment. We're not going to be able to close all the spaces only with brackets, because the problem is that if we try to close, for example, this space, and we have this overjet and overbite, what we're going to do is we're going to send that patient to edge relationship in the overjet. We always need to leave a good overjet and overbite at the end of a treatment. And if we have this remaining spaces at the end, what we do is do some bonding or some aesthetic treatment. Okay, this is a case where we put the lateral incisor, we intruded a little bit, we left some space. So after the treatment, she can have an aesthetic treatment there. Now you can see a more bigger lateral incisor. We can see also the gingival margin. He had a gingivectomy, so you can see a more longer teeth, more aesthetic teeth. And this is the case. She had a very small lateral incisor at the beginning of the treatment. She had an ortho treatment when she was a teenager. This is when we were finishing the case. This is when we debonded the brackets, and this is at the end after the treatment. Now, in this case, she didn't have veneers. She had some injected resin treatment. That's more, it's more conservative treatment. She was a young patient, so we did not recommend to do veneers right now. But you can see how a beautiful smile looks there. Okay, another thing that's very important for us to understand is the gingival architecture, the gingival design. The classic heights of the gingival margin are always the lateral, the canine and the central incisors are at the same height, and the lateral incisor is almost about 1 millimeter or 2 under that. But in a more modern or modified, you can see that practically they're all going to be at the same height. Now, it's very important to have a correct gingival margin contour. You can see this patient at the beginning of the treatment. She had some, you can see here, a lot of discrepancy from the gingival margin. So we aligned the teeth, and at the end of the treatment, once we finished the alignment, we did some gingivectomy, a small gingivectomy with laser, and you can see how aesthetic this is, and it has a much more beautiful result at the end, with no bonding or no other kind of treatment. Okay, also a very important fact that we need to see is how much gingival exposure does a patient have. We call that a high smile is when a patient shows about 3 or 4 millimeters of gingival tissue. Now, the younger our patient is, it's going to be more acceptable to show a little bit of gummy smile. But why is that? Because with age, we all know that the upper lip starts going down. So we're going to have patients that have a smile like this, that don't show a lot of incisors. Now, what we can do with ortho, we can bond our brackets a little bit more gingivally, so we can extrude a little bit more. We can what's called the small arc protection bonding, a little bit more gingival, so we can show a little bit more incisor. Now, sometimes our teeth are not that long, so we need to do some veneers or some aesthetic treatments so they can have a more vertical incisor display, and that's more aesthetic. Now, this is a medium smile that you can say it's like we could call about normal or in a medium range. So if we have a patient that looks like this, it's a teenager or a young patient, it's okay. Not always we need to send this patient to a gingival treatment or surgical treatment. It depends a lot on how much exposure do we have. Now, in this case, I'm going to show you 3 different patients that have almost the same lower facial height. And we can see this patient shows a lot of gingival tissue, but she has a very short upper lip. This patient has an average medium smile, and this is a patient that's around 45 years old. You can see that she doesn't show any incisor when she smiles. So we have the 3 different situations here. Now, in the first one, what we can do is intrude a little bit and do some gingivectomy. But in this patient, what we need to do is do a more higher bonding of the brackets, so this smile shows more to our patient. Now, another important fact in the smile is, to leave a buccal corridor, no negative spaces. Now, is in some cases that we do or perform extractions, we can see at the end of the treatment that what we do to the arch form, we like narrow it, and we leave this arch form like this. It's very important to try to leave our arch form a little bit more broader, a little bit more wider, and because that's more aesthetic, because our patient shows more teeth. We can see here that's a wider, a buccal corridor. And it's this case of the patient. At the beginning, she had a very narrow upper arch. So we aligned, we used like a broad arch form. And you can see at the end, she has a more broader, more beautiful smile. It shows more teeth. Okay. Now, another thing that's very important is to see when you have a cant of the occlusal plane or a midline deviation, like in this patient, you can see. And sometimes when we're not talking about a skeletal situation, we can put some tads and we can intrude the other part, and we can start using temporary anchorage devices, tads, so we can modify the cants that we have. Like in this patient, she began the treatment, she had a little bit canted, she had some gingival exposure on the left side, so we put a tad and we leveled this, we intruded a little bit on this side. At the end, we did some gingivectomy, some aesthetic treatment, and you can see a more beautiful smile at the end of the treatment. In a little while, I'm going to show you this case complete so you can see it. And it's a very interesting, because it has a lot of features about smile design there. But we can do this also with our treatments. And well, something that's very important, the angulation of the teeth. We're not looking for protrusion of the teeth. So one part, very important part for our treatment is going to be always the retraction of the upper incisors, to leave them that they could be parallel to the nasum pogonian plane from soft tissue. And that's the correct position that we want to put our teeth. So it does a very, very life-changing for our patients to retract or retrude the incisors when they have this situation. And this we do with ortho. Also, when we're talking about the shape of the teeth, color, this is more an aesthetic treatment, but we can offer this also to our patients. At the end of the treatment, we can, like in this patient, that she had a lot of wearing because of malocclusion. So at the end, we did, you could do some aesthetic treatment, like bonding on this teeth, and you can see a more bigger, more beautiful teeth at the end of the treatment. So this is very important for us to see this from the beginning of the treatment, so we can tell our patients that at the end, they're going to need some aesthetic treatment. Okay. And another important thing, that the position of the incisors is very important, because if we leave a correct position of our incisors, we're going to have a more beautiful lip protrusion. I don't know in Iraq, but here in Mexico, there's a lot of tendency for women to start injecting, like silicone or a lot of injections in their lips, so they can look like a more protruded lips. So in this patient particularly, what we did, we changed the position of the incisors, the angulation of the upper teeth, and at the end, look, she had a more protruded and more beautiful exposure of her lips. In this side, we can see like she had a very a profile that was retruded, and at the end, she had a more protruded on her lips. So it looks much better, more aesthetic for her. Now, this is the 10 commandments of aesthetic smile. I strongly should suggest you see this article. You start seeing these features when we do some diagnosis of our patients. Okay. Right now we're going to start talking about what's smile design. Okay. Now, what is it? We're going to see how you're going to do it, and how we can plan our treatments with this concept of DSD. Now, first of all, DSD is a trademark, and it was made by Dr. Christian Coachman. He's from Sao Paulo, Brazil. He is the owner. It's like a trademark, and it's a concept also. And he is a aesthetic dentist. You know, he's working with all of emotional dentistry. He works more in aesthetic, and he's also a dental technician. Now, the concept of the digital smile design was made by him, so we can have a more interdisciplinary communication, you know, like with the dentist, with the restorative dentist, with the technician, with the orthodontist, with the period, with surgeon. All of our, you know, all of our specialities integrate in one decision and treatment planning. So this is a very a visual way that we can show our patients what we want, and what we want to do. And it's also a very easy way, so we can tell the technician, we could tell the dentist, we could tell the periodontist exactly where we want to leave the teeth. And or they can tell us, you know, our colleagues tell, hey, to the orthodontist, they can tell you, George, I want you to put my incisors in this position so I can do this restorative treatment. So it's an interdisciplinary communication tool. Now, what's about that, we have some different templates. And now one of the important things in smile design is that you need to take good pictures. You can do this with an iPhone, you can do this with a Android phone. There's right now a lot of the phones right now that we have, the smartphones have very good cameras, but we suggest that you use a little bit more professional camera if you can, with the ring flash, or if you can with soft boxes from Light. You're going to see a lot of different things. You don't need to have a very expensive camera. You only need to have a camera with good light. Now, you need to take a good picture of the patient when it smiles, and you also need to take a picture of the upper arch with the contrast, with the black contrast. And with that picture, we can start doing, you put them in the program, in the application, or you can use this in Keynote or PowerPoint, and you can start doing the different designs. So once you have the pictures, you use these templates and you integrate them to the pictures, and you start like designing the size of the teeth, how you want to leave them. And it's very visual because it helps us a lot to understand where we want to put our teeth. Okay. Now this is very different templates that we use. We have this templates for the proportion of the teeth between the width and the height. You can see a 75%. This is about a normal range in the incisor. But if you have more bigger range, now we're having teeth that are, you know, more square or worn. This is a proportion, also this proportion mesh that we put it on the photograph, and you can easily see, you know, it's very visual. That's what's important. You can easily see where we have the teeth that doesn't have the correct size. Now, we also have to take into account the lips, because a lot of times we're going to have asymmetrical lips on our patients. Okay, now once you have this, you can do this with the DSD app. You can do this with PowerPoint or Keynote. Now, from Instagram, this is a post that I saw from Dr. Coachman. He put this around some years ago, and what it says that the DSD, or digital smile design, it's a concept, and it's a company. You know, the concept, you can use it with anything. You know, it's free. It doesn't mean that you need to buy the application. If you want, you can do it, but you can also do it like I tell you, if you take a good picture, and if you know how to use, or it's easy for you to use your Keynote or your PowerPoint, you can also do it with your patients. I do this with Keynote. I don't use the app, but it's just practice. You need to practice to take the pictures, and then you practice to use this meshes of these templates. Now, this is something that's very important. You know, the better the smile designer we become, the more we see the benefits of orthodontic treatment. Now, this is very important because a lot of restorative dentists, when they have malocclusions or the teeth are not aligned, they do veneers or crowns on those teeth. Now, when you do that, sometimes you need to do root canals, and a lot of times we can see a lot of patients that's not the best treatment. It's better for any dentist to first have their teeth aligned, and then you can do the restorative treatment. Okay. So this is a phrase that I like a lot, but it says a lot of what we're doing, that a goal without a plan is just a wish. And for us in orthodontism, like a profession, I could say about me, you know, I graduated around 20 years ago. And at the beginning, what I did, I just put the brackets on. I just change the wires, and I was reacting to how my patient's teeth moved. You know, just change the wire, and you follow the sequence. But I since no in the past of the years, or in this time, I have learned that if I have a very established goal, how I want my teeth to come at the end, it's going to be more easier for me. Because if you only start changing wires, you're only just wishing, to have a good occlusion at the end. But if you exactly know where you want to put the teeth, that's much better. Now that's what we do with aligners when you do a virtual setup of the occlusion at the end. So you fabricate your aligners to get to that goal. That's the same now, but we weren't used to do that in ortho. Now it's very important to understand that if you have the plan, it's much easier to do it. Now I'm going to show you some cases right now. This is what we want to all see. Now this is a 40-year-old female patient that came to the office. She had some orthodontic treatment when she was a teenager, but she came into the office because she wanted some veneers. Now we can see that she has, it's very fairly aligned, the upper teeth. She has, we can see here that she has more gingival display on this side than the other. But if you look closely, we also have an asymmetric, it's an asymmetrical upper lip. This side it goes more up than the left side. So she shows more gingival display on this side, okay? Now, if we see the intraoral pictures, you can see it's not a difficult case, but we have in the lower part, we have a very, some malocclusion. This lateral incisor, it's all the way out. Now, this, you can see the curve of speed, you can see the canine, we have some bad alignment on the lower, but on the upper part, it's fairly okay. She also has some restorations here. So this is the case. Now, we have here the Ceph, you can see it, and the panoramic x-ray. She had an extraction and she was preparing for an implant. Now, what would you do in this case? Now, of course, in my office, I work with my wife. My wife is a restorative dentist. So she was looking for, the patient was looking for an aesthetic treatment. But the problem was that she had, the lower teeth were not very well aligned. You can see here. So we did this situation and we were telling the patient that she needs a little bit of brackets, but the patient didn't want to have brackets. She said, I don't want to use brackets. I'm too old for that. And we said, it's going to be better for you if you put brackets, because then it's going to be more conservative, the treatment. But because we needed to do then upper veneers and lower also, but she has very healthy teeth. So what we did in this case, we did what the concept of digital smile design is. Okay, you can see this is the upper teeth. So the first thing that we wanted to show her how her teeth were going to look at the end of the treatment. And if she sees how they're going to look, it's more easy for the patient to take the decision to do the treatment. Now that's the concept of emotional dentistry. So what we did, this is, you put some rulers, you calibrate this on the size of the patient's teeth. So we put these rulers, we can see this discrepancy. We have 2 millimeters from this plane. It's in the interpupillar plane that we transported down to the mouth of the patient. And we can see the width. We can see that she has a little bit short teeth. So we start using these templates to see we have a very good proportion, measure the proportion. So we got this template, we put it on the teeth, we put them exactly like we want this patient to look at the end of the treatment. And this is like the DST, the planning that we have. So we send this to the technician, and the technician sends us a wax up of her teeth. We can see she had a wax up of from second premolar to second premolar, to the second bicuspid, all 10 on the upper teeth, all 10 teeth. And you can see this is a mock-up done with tellure resin. It's a resin that you put on the patient. You do on the wax up. You put some silicone on it, and you have a key. You put it on the patient's mouth, and you take them some pictures. And then the patient can see how he's going to look at the end of the treatment. Let me show you how. This is the dentist, my wife, that she did the wax up. Now you can see here. This is the mock-up on the patient. So we put it on, We take some pictures and we compare. These pictures are from the same day. This is without the mock-up, and this is with the mock-up. I'm going to go back a little bit. Okay, now you can see how different her teeth look. They're more longer. In this case, we're contemplating do some gingivectomy, but you can see the color, the size, the proportion. That's what the patient wanted. So I told her, if you want this treatment, you need to use brackets in the lower. And the patient says, go ahead. But it was very important for her to take this decision once we showed her this. If we wouldn't show her that, she wouldn't understand the concept that I needed to align the lower teeth. So she told me, I just want to have them fast. So we were going to do a very fast alignment in the lower arch so she can have her veneers. And as orthodontists, we know that this is a very easy case. We have the upper lip. You can see how we have an asymmetrical upper lip. So it looks much better on the right side. So what we did here, this is a picture of her. And she was very happy with that. So this is the upper, how they look, and at the lower, how with the mock-up. Okay, now we started in March, the treatment. We did a gingivectomy on the upper, and I bonded the brackets in the lower. We put some self-ligating brackets. We have a 14 copper night tie. You can see it's not that severe of a problem, but it's going to be easy, to do. This is not. This concept is for aesthetic treatments, not for you can do it with any patient, but you can see, practically on our, and the ortho part is going to be very easy how we did it. So by May, we started in March. By May, this is the mock-up in the beginning, and these are the veneers already put on her mouth. So you can see they look very similar to what we had on our wax up. We send this to a technician. That technician does the veneers, and you can see that they have a very natural color, not that white. And she was very happy. So we were already on an 018 night tie wire in the lower. The lateral incisor was already aligned, so she was very happy. And you can look how different her smile looks there. Now, from this point on, the patient was, she was on me because she wanted me to take the brackets off. She was ready to take them out. Now by August, we used a 19/25 TMA and just doing some first order bands, some details that we needed to correct there with the canines and the laterals. And you can see that's already finished this case. So by, the lower, it's very easy. It was not a difficult case. And by October, we took the brackets out, and you can see the end result. So we're talking about we're talking about 7 months of treatment. She has a little bit of swelling in the lower. This brackets, this is a Damon Clear from Armco. This is a very wide bracket in the lower. So it's been my case, when I take these brackets out, immediately you have a lot of gingivitis. You have a lot of swelling in the lower gingiva. But this is the day we took the brackets out. But you can see the upper, it looks very nice. We have finished our teeth. She had a little bit of bonding in the lower incisors and the incisal edges, but now we can see the before and the after. It's a very big change. We leveled a little bit the curvus P. We made more longer teeth. It was more like a leveling and aligning treatment, but it was very fast. And you can see at the beginning, and this is the end, the day we took the brackets out. This is the mock-up, and this is what we wanted to have, and this is what we had. It looks very similar. Now, the patient was very happy, and it was a very good treatment. It was very fast, very, very interesting to do this concept, because if you have some struggles for your patients to understand your treatment plan, you can use this concept very easy. Now, how can I do this in ortho? This was a very simple case. We did veneers, but what if I have a very, very more difficult malocclusion? Now I'm going to show you this next case. Then when we use this concept for bracket placement, this is a 34-year-old male, and he came to the office a few years ago, and this is his smile. I'm going to show you a little bit more closer. Now he has, I'm going to show you this picture. He has a little bit of a symmetrical, like a little to the left. The mandibles, it's a little bit to the right. Sorry. He has some mandibular deviation. asymmetric face. So that position does him to, he ward off a lot of his upper incisors. And you can see this cantment of the lower occlusal plane. You can see the lower arch, how it's, it's asymmetrical because of the laterognathia of the mandible. And we have a class 1, it's not that difficult, understand the case, but what are we going to do here? So in this case, we need to do an aesthetic treatment, but we first need to align. So what we did to this patient also for him to understand how we wanted to finish the case, we did also a mock-up. You can see the overjet and overbite. He has a very severe wearing of his teeth. In Crowley, he has his midline correct, but you can see the anterior open mouth, and this is the overbite. And this is the picture I tell you need to take with the contrast, so we can see the different sizes of the teeth. So what we needed to do, we also did this concept. We did the smile design. We measured the teeth. You can see now in this picture how all the gingival margins are canted to the left. They had more extrusion because of the position of the mandible. So we have a lot of asymmetry in this case. So what we did like a plan. We had a mock-up. This is the how can I call it, the cast. This is the mock-up now, and this is the wax up. We have all the 4 teeth, also the canine, a little bit the premolar, the bicuspid. So this is the initial. This is with the mock-up in his mouth, and this is a overimposition. We can see a lot how much of enamel tissue this patient needs to have a more aesthetic smile. Okay, now once we did this, we take some pictures of the patient, and look, it looks much better. So we take the pictures, and the patient says, yes, I want that. So we did the bracket placement. Now we're going to bond the brackets so we can level the teeth and we can level the gingival margins, so it could be more easy to do the bonding. Now, in some cases, what we do ideally is put our brackets on. If we're using metal brackets, we put our brackets on, and once we align, we take the brackets and we send this patient to have some restorations. But in this case that we have aesthetic brackets, sometimes when we debond the bracket, it has a very high percentage of the bracket to fracture. So what we're going to try to do is put our initial bonding of the treatment so we can level and align and not have the need to take the brackets out. Now I'm going to show you how we did this. And I'm gonna share with you the 3 articles. This is from Dr. Germán and Dr. Stephen Chu from the AJO. This is from Dr. Tom Pitts, that's talking about the smile arc protection that I talked a little bit at the beginning. And this is from my friend and teacher, Dr. Balut, that he's talking about the strategies based on smile aesthetics. We're going to see all 3 of them. Now, the first thing that we need to do is to calculate the ideal size of the teeth, okay? Now, in this article of Dr. Germán and Dr. Stephen Chu, they're talking to us about what are the ideal sizes. We all do the Bolton analysis to see where we have more structure on the upper or on the lower. But with this study from Dr. Chu and Dr. Germán, they say that, for example, if our lower incisor, measures 5 millimeters, like we see here, X, the upper incisor should measure 3 millimeters more, measure distally. So if this is 5, this should be 8. Now, if this measures 8, our lateral incisor should be 2 millimeters shorter. It should measure 6, and our canine, it should measure 7. Okay. Now, this is very important because sometimes we have very worn teeth, or sometimes we don't even have teeth, in some patients, and we need to know exactly what's the size that we need to leave at the end. So it's very interesting, and we don't need to do a very sophisticated analysis here. We can do our veneer and measure it to a 0.5. It doesn't need to be that exact. It's much easier also when we're trying to do some stripping or interproximal reduction, that our central lower incisor measures, it's 0.5 smaller than the lateral. That's the normal size of the teeth. So we can see in which teeth we need to do interproximal reduction. Now, we measure the teeth like you see here. It's very simple. Measure the cast, and we have the size. Now this template comes in the article. So we measured the width of the teeth, and it was 8 millimeters wide, both centrals, upper centrals. So what they needed to measure is going to be 10.3. Okay, you can see on the upper how if this was 8.5, it should measure 11 of height, and if it's 9, it should measure 11. Now this is very interesting because you can share this table. This article was done so you can do this into interdisciplinary planning. Okay. So once you measure the teeth and you know the ideal size, then we need to understand what the vertical incisor display. Now this is from Dr. Pitt's article from 2017. This is on the JCO, and what he does, you can see all his treatments look beautiful, at the end. But he does a lot of gingival recontouring and enamel augmentation. He does a lot of bonding on his teeth, so we have a very beautiful smile arc. Now, this is the concept of vertical incisor display. How much teeth are you showing? And it has to do with the bracket placement. Now, once we have that situation, we subtract the ideal height of the teeth to the real crown height. Okay, I'm going to show you how we do this. And I bond my brackets using Dr. Balut's table. When we have a low smile, with no exposure of the teeth, we bond it at 7. What's the central incisor? When we have an average one, it's about 6. And when we have a high smile, we put them at 5. The lower arch always goes at the same height. But the modifications that we do, it depends on if we have a more high smile or a lower smile. Now, how we do the bracket placement, this is like a little so I can show you, like, this is very similar to our patient that we had. So once we measure the width of the teeth, now in this case, it's 8 millimeters wide. And the real size of the crown is 8.5. So regularly, since once we have the width, our ideal height of the teeth should be 10 millimeters. So we're 1.5 millimeters short. So if we are going to bond our brackets at 6 millimeters because of the smile display, so what we're going to do from the 10 millimeters, that's the ideal size, we have a discrepancy of 1.5, and my ideal position or height of the bracket is going to be 6 millimeters. I'm going to subtract this difference, and our bracket height in this patient is going to be 4.5. So this is how we did it, the calculation in all the cases. I'm working right now to do a paper on this, so I hope we can publish this. Now, once you put the bracket, you start your leveling, your aligning, and once you start going up to a more wider arches, an 18 or 14 by 25, once you can do this, once you're in a more wide arch, now you send your patient to do the enamel reconstruction here. So this is what we did on this patient. I'm going to show you. Now by October, we bonded the brackets in August. By October, we aligned them. Now we can see that the brackets are all at the same height. Right now, in the aligning in the first first stages of alignment, sometimes we have some spaces that open. That's okay for me because I wanted to bond this bracket. So you can see this bracket that's very, very incisal. So in the office, we didn't even need to take the brackets off. We did the bonding. I didn't do this. It was we did it in the office. Now we have a more ideal size of the teeth. Now it's more easier for us to work with this, and it's better for the patient because he's going to be more happy with the result. So this is by March. You can see the aligning. He has still some cantment, but we have a better size of the teeth, so we can work better. Now he has a much better overjet. Now you can see the different color because this patient he didn't have very good hygiene, but well, that's another issue right now. But we can see how it looks much better. We're working more easier here. He's going to need a gingival procedure on the lower arch, gingivectomy. But you can see now all the reconstruction that we have, and it's like I tell you, it's more easier to work with this. So he has still some spaces. We're still leveling and aligning, but it looks much better. Now, this is in March. I took this pictures during when the lockdown came, because I had him programmed for the bracket debonding, and he's going to need some aesthetic treatment at the end, to change those bonded resins. But he hasn't come back, right now because of the lockdown. But you can see I took the brackets off. You can see the position of the incisor. It looks much better. Obviously, he has a little lateral nature to the right of the mandible, but this is the end result. Now we have a much better position of our incisors, a better overjet, a better overbite. He still has a little cantment in the lower. You need to reconstruct from the canine so he can have a better deocclusion. But you can see the overjet and the overbite. Now it looks much better. I always tell the dentist to do this a little bit more wider, the incisal edge, so we can protect more the overjet. You can see the little cantment that I was telling you. And he still needs some aesthetic treatment, but right now he looks much better from the beginning. Also some treatment here between the canine and the lateral incisor. Here we have a bonded fixed retention in the lower. And this is the initial, this is the mock-up, and this is the end treatment. So you can see it's very similar. Now it's very important for us to if we visualize what we want to do at the end, we can have a more similar end result here. We're going to see some from initial and final. Okay, so we corrected the overjet, the overbite, the gingival margins were also leveled. Now it's much easier once we do this. And the interesting here is that we planned it since the beginning, so it was much easier for us. Okay, he still has like his symmetrical lower arch, but it looks much better here. Okay, that's the mock-up and the end result. Okay, I'm gonna go a little bit more faster because it's almost an hour. I still have 2 more cases that I want to show you. This is another similar case. It's a 23-year-old patient, the one that I showed you at the beginning. She's a very beautiful girl, and she smiles very big. She has a very wide smile. She smiles a lot, but you can see the incisors are all right. They're retroclinine. They're retuded. She has some gingival exposure on the left. She also has some asymmetrical lips. So since I saw her, I can see, the different sides of the teeth. She had already 2 orthodontic treatments. So I was going to be the third doctor with her. And she says that there was something about her smile that she didn't like. She didn't know what was it. Obviously, us as ortho or specialists, we can see this, and it's obvious for us, the size of the teeth, the gingival exposure. You can see that she still has some malocclusion, but that's our job, we're the doctors here. So you can see the retrusion of the upper incisors. She has a very nice profile. Very like Mexican women that have very wide lips. Sorry, this is the front. You can see how we have very different sizes of teeth. She has a very deep overbite. And if we do this, we can see that she has a very low proportion teeth. It's very high. So what happened here? She had some wearing because of the tooth. Now, she had some wearing since the beginning of of her first treatment. But the dentist, the only thing that he did, he put the brackets, he put a power chain, and he only retracted the teeth. He didn't even look at the situation. So I told her the first thing that we needed to do was to level the teeth so she can have some aesthetic treatment and we can work with it. So we did exactly the same from the other patient. Let me show you this. It's very easy. It's not a very difficult malocclusion, but she was going to use also some aesthetic brackets. So we did the planning. We measured what height we wanted the teeth. They were 8 millimeter wide. So we do this planning here. All this, what we do with PowerPoint or Keynote, it's very interesting. But to show you how it's done, I need to show you about 1 or 2 days, because you need to sit with the computer, you need to practice. It's easy once you practice it, but to show this on a lecture, it's very difficult. But we bonded the brackets. We did some initial leveling. You can see this canine. I didn't, even though I planned it very well, I didn't bond it at the correct height. I tried to debond this bracket, but it was very, very well bonded. So I just did a step up here to compensate this. And you can see the teeth. She had some composite reconstruction on the upper teeth. Now we can see a better overjet, a better overbite, and a much more proportionate size of the teeth. Okay, they look a little bit better, but it's very important for us to take pictures. I take pictures of my patients at least every 2 or 4 months, and I took this picture. She came in, and I still saw a lot of cantment on the occlusal plane. I know that I could do some gingivectomy here, more larger than incisor, but I needed to intrude a little bit this part. So what we did here, did some analysis. So I decided to put an implant, TAT. All right, let me go back a little bit. Well, it doesn't work here. I have, oh, here it is. I have a video. So what we put a little implant. This is from Ormco. This is a vector task that's 8 millimeters by 1.4 millimeters. That's the diameter. So we need to use very small implants if we want to put them in the between the roots. So it's going to be more easy for us to place these brackets. I'm going to go ahead here. I'm sorry, I had the video in how we place the. Oh, let me see if I can put it on. Well, I'm going to go a little bit forward because of the hour. Okay, we put the implant there. You can see, and it's very important for us to take an X-ray after we put it, so we can see that we're not touching the roots. Now we have here what the amount of force that we're going to put here is about 2 ounces. That's 60 grams. It's very light force. We don't need much heavy forces here. This is the X-ray. We can see it's between the roots, so it's in a very good position. So we started with this chain. You can see that's almost, it's not very tight. It's very, very light forces. It's very important to put a ligature here on the anterior. This is a white ligature, so for the aesthetic reasons, because of the aesthetic brackets, we can use a metal ligature also. So what we're going to do, we're going to start changing this chain every month, so we can correct this cantment. Okay, this is when we place it on. Now by April, we started now using the implant, so we can have some anchorage, so we can use some elastics to close the bite. Now at the beginning, it's very important to measure. I use this little ruler and take a picture. At the beginning, the distance from the TAD to the arch wire was 13 millimeters. By January, it was 12.5. By February, it was 12. And by April, it was 10 millimeters. You can see the difference. It's only 3 millimeters, but it changed the distance between the TAD and the arch wire. It doesn't mean that was the intrusion. It was just the distance. So now by May, I'm using this like indirect anchorage. We can see now the position of the incisor looks much, much better. And I'm using here a metal ligature, so I can use some elastics to close the bite that we open once we intrude that side. We use here some medium elastics just to close the bite. Now, this is the day we put the brackets on. You can see the inclination of the incisors. Now, this is when we finish the intrusion. You can see the big difference here. Now, this is a great big change for that. Now, what we did here, what we did here was, it was not a complete intrusion. The only thing that we did was to we changed the inclination of the tooth. Now, it's very important for us to understand that the force that we apply on the teeth, we have to understand that it comes from the bracket. Okay, so in this case, if I'm going to intrude a little bit, or put of some force that's gingival, the reaction of my teeth is going to be like this. This is what happened in our patient. Now, if we put a force that goes incisively, like for example, if you're bringing down a canine, well, the crown is going to move like this. Okay, this is what happens also when we have some, in a 2x4 that we put some open coils, our teeth start flaring to the front. And in cases when we do extractions, what happens to our crown? It goes back because we're lower from the center of resistance of the teeth. Now, this is what happened in her case. Okay, you can see the beginning, you can see the advanced treatment. This is on November. This is when we finished the case. So we took the brackets out. We send the patient to do a gingivectomy and to do some bonded composites here. We did not see, even though she had different color, an enamel that has a lot of different colors. She was too young right now. We suggested her to wait a little bit to get the veneers, but you can see she's still a little sore here from the gingivectomy, but we can see a much better size of the teeth, the inclination of the upper incisor, the overjet and the overbite. Now we can see the beginning and how we ended the treatment. It looks much better than when she started the treatment. Now, she was very happy with her smile. We were also too. And this is the important thing, now she says, I do like my smile, because at the beginning she, patients, they sometimes they don't understand what's the thing that they don't like. So it's very important for us to do this planning and to do this correction. Okay, you see the incisors, how different they look. Now I'm gonna show you fast. This is the last case that I'm gonna share with you today, and it's also, we're talking about a patient that's she's 36 years old. When she smiles, she doesn't show a lot of teeth. Now, if we see this picture, we can see that she has some malocclusion, some wearing of the upper incisors. She doesn't smile that much. We can see this flat profile. And when we see the picture, we can see, the different sides of the teeth. We can see the wearing, the overjet, the overbite. She has a very narrow upper arch, crossbite here. And I always take this picture with the mouth open because it's very important for me to see the Spee curve and the Wilson curve. Also to see how the lower incisors are, because typically we always take this picture, but we need to take this one also. I recommend you to do this so you can see your lower incisors. Now, this is the overjet. We can see the wearing of the teeth, the overjet and the overbite. And you can see, narrow upper arch. Now, this is not a very difficult case also. It's a more leveling and aligning, but we need to understand that we need to look to leave this case the most aesthetic possible, having the situation of a different teeth size. So we start doing the treatment. She has you can see a much longer lateral on this side. Now, one of the problems that I had with this case was that that she didn't want to have an aesthetic treatment at the end. She was against that. She told me, doctor, I don't want to have any kind of veneers. I don't have any kind of composites. And, you have to respect her decision. So we started aligning. That's why we put this lateral not too high, because I didn't want to leave this with very open situation with this lateral. So I started working here. I'm using here a torque spring for the lower canine. And we took the braces off on November. Now, I show you this because you can see this lateral. Ideally, it would have been better to leave it a little bit more gingival. Now, this day, the day I took the brackets out, the patient tells me, doctor, I want to have an aesthetic treatment. And I told her, you should have told me since the beginning, because I wanted to intrude this teeth a little bit more so it could be more aesthetic. But I didn't, argue with her. So what we did was, you can see the end of the brackets. So we have a more better arch form here, the upper and lower. So what we did here, we did the planning as we did on the other cases. We have a very large discrepancy here, almost 4 millimeters, and these are 2. So in this case, we measure the teeth, we put a mesh there also, the templates. And we have, like how we want them to finish. So you can see here that she has on the lateral, centrals, on this lateral also, and even on the bicuspid, because it was very worn. So we did a mock-up here. Now it's a very thin, it was breaking here. But what we did here, we put the mock-up and we took some pictures of the patient. Now this is a few weeks after we took the brackets off. This is her smile at the end. You can see it looks beautiful. So these are the pictures. We did the mock-up. And you can see the pictures, how her smile looks with the mock-up. Now, you take these pictures, you send them to the patient, you can send them by mail, by WhatsApp. And generally, they show this to their husbands or their family members. And when they see that smile, that's when they decide that they're going to do this treatment. So she told us she wanted the treatment. So she came in. It was very, this was a very conservative treatment also with some composites there. You can see the smile art looks much, much better with the mock-up. So this is by December. Now you can see the smile once the treatment was finished. She shows more incisors. It's more beautiful shape, more proportionate. She didn't show that much of a teeth. That's why the gingival margin wasn't that big of a deal, but you can see the difference between one side and the other here. But it looks very good. Now, I told you that I usually tell the dentist to leave the incisal edge a little bit wider so it protects my overjet. And you can see now we have a flattened curve of SPE. It's going to be more stable, the SPE curve at the end for the relapse is very important to take that in count. And it's a very conservative treatment, but it looks much, much better at the end. And we can see the initial and the final. You can see we have a more broader arch. We level the curve of SPE. It looks much, much better. The size, the proportion of the teeth change, and the angulation, that's very important also. It's very typical for our patients to have, that because of the wearing, the teeth start a passive interruption and they start changing the inclination. You can see the arches, they're aligned there. Now you can see the smile, the beginning and at the end looks much, much better. She looks younger. And the position of the teeth also helps us a lot with the protrusion of the lips. That's the case that I showed you at the beginning. So we can do these changes with our bracket position, with our teeth position. It's a very, very great tool that we can use. This is another picture of my city, and I'm about to finish right now. I just want to show you, these are my students. I always put them on every lecture I take. I do because I say, I always say that I had great teachers, during when I was studying and during my life. But when you have students, they're your better teachers because they're always motivating you to be a better teacher. So this is just a small group of the students that I've had during the years, and I'm very proud of it. And well, it's very important for us to help the younger generations to see a better way of doing ortho. I want to thank doctors for the invitation. It's a great honor for me for your invitation. And like you say, this is another phrase, just to finish, that says that the greatest enemy of knowledge is not ignorance, it's the illusion of knowledge. Sometimes we think that we know a lot, but in reality we don't. Every day we can learn something new, and it's very important for us to be open to see new ideas, to see new ways of working, and to implement them in our office. You can know a lot of things, but if you don't implement them, it's like if you didn't know them. So I just want to say shukran. Thank you very much. And it's been an honor to be here.